Blood Vessels and Hemodynamics, Part 2. Capillary exchange. Substances cross capillary walls by several different methods. There's diffusion, transcytosis, and bulk flow. Now, diffusion, if you remember, diffusion is the movement of a substance from an area of greater concentration to an area of lesser concentration. And so substances such as oxygen, carbon dioxide, glucose, amino acids, and some hormones are going to cross capillary walls via simple diffusion. Transcytosis, large lipid insoluble molecules like insulin cross capillary walls in vesicles via transcytosis. In other words, we're not going to go directly to where we want to go, but we're going to go first into a cell, pass through that cell, and then pass back out of that cell. So it might be brought into the cell through phagocytosis, transported to the opposite side of the cell, and let go through exocytosis. And then bulk flow. Bulk flow is a passive process in which large numbers of ions, molecules, or particles in a fluid move together in the same direction. Bulk flow occurs from an area of higher pressure to an area of lower pressure, and it continues as long as the pressure difference exists. So bulk flow is more important for regulation of the relative volumes of blood and interstitial fluid. Filtration and reabsorption. Filtration is pressure-driven movement of fluid and solutes from blood capillaries into interstitial fluid. Now we look at blood hydrostatic pressure, or BHP, and interstitial fluid osmotic pressure, IFOP, and this provides, or promotes, I should say, filtration. So let's go back. Let's think about this. Blood hydrostatic pressure. That's going to be the pressure inside of a blood vessel. So every time the ventricles contract, usually that blood hydrostatic pressure will go up. When we move to veins, typically that blood hydrostatic pressure goes down. Okay, so arteries, it's up. Veins, it typically is down. Okay, so again, just think of the pressure. Well, think about the pressure, water pressure inside of a hose. Okay, a water hose. If there's any kind of leak in that hose, you're going to see water squirting out. Okay, same thing here. We're exerting a certain pressure within the blood vessel. Okay. And then interstitial fluid osmotic pressure. So now we're talking about outside of the blood vessel, and we're talking about the osmotic pressure that interstitial fluid, that fluid that's in the tissues, is going to exert. So what does that mean? Let's think about the definition of osmosis. Osmosis is the movement of water through a semi-permeable or selectively permeable membrane from an area of low concentration of solute to an area of high concentration of solute. And my definition of a solute is, and then write this down, my definition of a solute is a water magnet. So in other words, where there's more water magnets, that's which way water is going to flow. Okay, think about, on the table, putting down a couple of magnets on one side of the table, a whole pile of magnets on the other side of the table, and throw some paper clips in the middle of the table. Which way is most of the paper clips going to go? It's going to go to where there's more magnets, right? So think of solutes as water magnets. If we have some solutes such as sodium, or proteins such as albumin, or sugars, for instance, they all exert what we call an osmotic pressure. Okay? They are going to draw water toward themselves. Okay? So here, what we're looking at is pulling fluid out of a blood vessel. And one way to do that is through increased blood hydrostatic pressure plus the osmotic pull in the tissue trying to pull that water out of the blood vessel. Okay? And then reabsorption is pressure-driven movement of fluid and solutes from interstitial fluid into blood capillaries. So now we're going the opposite way. We're going from the tissue back into the blood vessel. Okay? So interstitial fluid hydrostatic pressure, or IFHP, and blood colloidal osmotic pressure, or BCOP, promotes reabsorption. So let's say that again. Interstitial fluid hydrostatic pressure. In other words, the pressure that's exerted by the tissue trying to push that fluid back into the blood vessel, which, by the way, there's not much pressure there really. Okay, so that's rather low. But the blood colloidal osmotic pressure, in other words, the albumin that's in the blood vessel is exerting its osmotic pressure, its osmotic pull. Okay, so albumin is a very strong water magnet. Okay, it's a very strong solute. So it's pulling or almost sucking that water out of the tissues into the blood vessel. Okay, so how do we get tissue or fluid out of the tissue and into the blood vessel? By applying pressure, hydrostatic pressure, in the tissue, and then exerting that pull within the blood vessel itself, that osmotic pull, to pull the fluid out of the tissue and back into the blood vessel. So let's look at a picture of that. So net filtration pressure is going to equal the blood hydrostatic pressure. In this case, the blood hydrostatic pressure is 35 millimeters of mercury. So that's how much pressure is pushing fluid out of this blood vessel. Okay? Plus interstitial fluid osmotic pressure. Okay, so here we go. So the interstitial fluid osmotic pressure is about 1 millimeter of mercury. So we add those two together. So 35 plus 1. So that's going to give us what? Carry the 1 divided by plus. Okay, so 36, correct? I didn't even have to ask Siri for that one. Minus the BCOP plus the IFHP. So in this case, BCOP is going to be 26 millimeters of mercury pressure. So in other words, being able to pull or suck that water out of the tissue into the blood vessel. Again, this is what albumin is doing. Okay. Minus the interstitial fluid hydrostatic pressure, and here's our interstitial fluid hydrostatic pressure, 0 millimeters of mercury. So we have 36 minus 0 is going to give us 10 millimeters of mercury. So on this side of the equation, okay, this side of the equation, since we came up with a positive number, that means we're able to push some fluid through this vessel into the tissue. Okay, we're still on the arterial side, so pressure is relatively high. Okay, When we go over to the venous side, remember veins are low pressure systems. So if we look at that, we have again our BCOP. So our BCOP on the venous side, blood colloidal osmotic pressure is 26 millimeters of mercury. So it's the same on both sides because we have the same amount of albumin. And I think I pointed to this when I was talking about this, but here's the BCOP up here. But either way, it's going to be the same because you're not losing albumin. Okay. So the BCOP plus the interstitial fluid hydrostatic pressure, okay, which again is 0. So what do we have? We have our 16 plus 1 for the interstitial fluid osmotic pressure, minus our 26, so that's the BCOP, plus 0 for the interstitial fluid hydrostatic pressure, is going to give us negative 9 millimeters of mercury. Okay. So since we have a negative number, that means fluid is going to flow out of the tissue and into the blood vessel. Okay. And again, we're looking at blood hydrostatic pressure plus interstitial fluid osmotic pressure. That's our, on this side, going to be the 16 plus the 1 minus the BCOP. In this case, the BCOP on the venous side is 26 plus the interstitial fluid hydrostatic pressure, 0. So we have our 16 plus 1, so 17, minus 26. Again, gives us negative 9 millimeters of mercury pressure. And fluid will flow out of the tissue and back into the blood. Okay? Now, if that doesn't happen, what's going to happen? Like, for instance, if you have low albumin count, okay, not enough albumin in the blood, what's going to happen? Well, that fluid is going to stay in the tissue and you're going to have swelling or edema. Okay. Now, there is a little bit of fluid that does stay in the tissue, and how we get rid of that excess tissue fluid is by absorbing it into the lymphatic system. So the lymph vessels are going to absorb that excess fluid and then drain it back into the circulatory system at a different area. Okay? So I hope that makes sense. So under normal conditions, the volume of fluid and solutes reabsorbed is almost as large as the volume filtered. So net filtration pressure equals blood hydrostatic pressure plus interstitial fluid osmotic pressure minus blood colloidal osmotic pressure plus interstitial fluid hydrostatic pressure. And it's like what I had mentioned before, that most of the fluid that gets pushed into the interstitium is going to be reabsorbed back into the blood vessel. Okay. Again, there's a little bit left behind. Excess of that goes into the lymphatic system. What's left over hydrates the tissue. So factors affecting blood flow. Blood flow is the volume of blood that flows through any tissue in a given period of time. And we look at it in terms of milliliters per minute. So total blood flow is cardiac output, the volume of blood that circulates through systemic or pulmonary blood vessels each minute. So cardiac output, we could say, equals heart rate times stroke volume. So again, heart rate, how many beats per minute, times stroke volume, how much volume of blood is pushed out of the ventricles with each contraction. And we can also say cardiac output equals the mean arterial pressure, or MAP, divided by resistance. Blood pressure. Contraction of the ventricles generates blood pressure. Blood pressure is determined by cardiac output, blood volume, and vascular resistance. The higher the blood pressure, the greater the flow. So let's look at some of these. Blood pressure determined by cardiac output. The greater the cardiac output, typically the higher the blood pressure. The higher the blood volume, typically the higher the blood pressure. If your blood vessels constrict, a couple of things happen. One, you're increasing, let's see, how can I say that? You're increasing volume, relatively speaking, okay? And because you're going to have less vessel to hold that same amount of volume. So relatively speaking, you're increasing the volume, so blood pressure goes up. But also as blood vessels constrict, you're also increasing vascular resistance. So that increases pressure. If you have blood vessels that are atherosclerotic, in other words, plaques are building up in those vessels, that's going to increase vascular resistance and increase blood pressure. Okay. When the heart contracts, if it is a strong contraction, that'll increase blood pressure. Vascular resistance. Now, resistance is the opposition to blood flow due to friction between blood and the walls of the blood vessel. The higher the restriction, the smaller the blood flow. And resistance depends on the size of the blood vessel lumen, blood viscosity, and the total vessel length. So the size of the blood vessel lumen. How big of the opening is it? Let's think about, again, a garden hose. Okay. If you have a small garden hose, you're going to have greater resistance in that hose. If you have a big, fire hose, for instance, you're going to have less resistance in there. Blood viscosity. If the blood is relatively thin, you're going to have less viscosity and you're going to have less resistance. If you're dehydrated, your blood is a bit more sludgy, a little thicker, so you're going to have greater resistance. And then total blood vessel length. So if you have a short piece of garden hose, you're not going to have much resistance through that. Now, if you have a 50 or 60 foot garden hose, you're going to have a lot more resistance. Okay, so to overcome that resistance, you might switch to a larger diameter hose. It's kind of the same principle with electrical cords as well. Kind of going off track here a little bit, but if you just have a small thing to run, some appliance, you would have a smaller electrical extension cord. If you're running something like I like to weld, if I'm running a welder, that's going to require a lot more electricity, and I'm going to need a much bigger, thicker extension cord. Because what's going to happen is if I run that welder off a tiny little home extension cord, there's going to be so much resistance in that it'll probably melt. Okay, so you can see where increasing the diameter will decrease the resistance. And the longer you go in length, the more diameter you need to make up for that, to reduce the resistance, basically. Venous return is the volume of blood flowing back to the heart through the systemic veins. It occurs due to the pressure generated by contractions of the heart's left ventricle. And venous return is going to be assisted by valves. Again, veins are low pressure systems. So when the heart's not contracting, the amount of pressure within the vein is going to be like zero. So as the blood oozes up in between contractions, it wants to flow back down. The valves stop that. The respiratory pump, or what we used to call, when I was a respiratory therapist, was the interthoracic pump mechanism. As you inhale and exhale, that helps to pump blood. And then we have skeletal muscle pump. Every time you walk and move, the muscles contract, and that squeezes veins, and that helps to push blood up toward the right atrium. Here we can see that skeletal muscle pump. So every time you move and contract those muscles, it squeezes the veins, pushing blood up. And when you relax, the blood wants to come back down, but it's stopped by these valves. Okay. Now, if these valves become incompetent, or if you're not contracting the muscles and maybe are seated for a long period of time, such as international flight, for instance, then you can run into some problems where blood will pool. And if blood pools and sits long enough, it can start to develop clots. And this is where people can develop what they call DVTs, or deep venous thromboses. So there have been cases where people have been on long flights, the blood is pooled, they've developed some clots, maybe they were at high risk for clotting anyway. Then they get up, they start moving around, that breaks the clot loose, so it goes from a thrombus to an embolus, comes up to the heart, goes through the heart, goes to the lungs, and boom, you have a pulmonary embolus. And that patient can actually die pretty quickly from a pulmonary embolus if it's large enough. If it's small enough, they'll have shortness of breath and maybe not have permanent damage, probably to that area where that clot went. But if it's small enough, that'll be localized. But again, these DVTs can be quite serious. And so if you're ever on a long flight, make sure you're at least contracting your calves and moving your legs and things like that to pump that blood out. Okay, hormonal regulation of blood pressure. Cardiac output is increased heart rate and contractility. The hormone that's going to do that is norepinephrine and epinephrine, and that's going to increase blood pressure. As far as systemic vascular resistance goes, vasoconstriction, and the hormones that actually cause vasoconstriction is angiotensin II, antidiuretic hormone, norepinephrine and epinephrine, and that will increase blood pressure. And as far as these hormones go, that's going to be covered in the endocrine lecture. Vasodilation, so how do we lower blood pressure? Atrial natriuretic peptide. Okay, that's a hormone. Where do you think that's made? Atrial. What did we learn about that has an atrium? The heart. So this is actually a hormone secreted by the heart. Atrial natriuretic peptide. And we'll again, discuss that more when we do the endocrine system. And then epinephrine and nitric oxide, again, can lead to vasodilation and decrease the blood pressure. Okay. Now, it might be a little bit confusing because we see epinephrine up here, increasing heart rate contractility, which helps to increase blood pressure, but it can also cause vasodilation as well to help lower blood pressure in certain parts of the body. But as you can see here, epinephrine can also cause vasoconstriction in other parts of the body, increasing blood pressure. So all of these things that we're looking at are not necessarily taking place at the same time systemically. Some areas are going to have increased pressure, some areas are going to have decreased pressure. And then blood volume. So as blood volume increases, such as with the hormone aldosterone and antidiuretic hormone, blood pressure is going to increase. And if we have blood volume decrease, such as with atrial natriuretic peptide, blood pressure will decrease. Now, autoregulation is the ability of the tissue to automatically adjust its own blood flow to match its metabolic demand for delivery of oxygen and nutrients and removal of waste. Physical and chemical stimuli can lead to autoregulation. Like I said earlier, that there might be some areas of the body where the blood pressure is a bit higher, other parts of the body where the blood pressure is lower at the same time. Again, this is where that autoregulation comes into play. Like, for instance, if you're working out and those muscles need more oxygen, you're going to get vasodilation and more blood flow to the muscles. Now, checking circulation, one thing that we want to do is oftentimes check pulses. And there are a lot of different places we can check a pulse. We can check the superficial temporal artery right here along the side of the head, so it's medial to the ear. Let's see, we have the facial artery. So we have the mandible, lower jawbone, on line with the corners of the mouth. So right there's the facial artery. The common carotid, lateral to the larynx. So here's the carotid. The brachial artery, right here, medial to the side of the biceps brachii. And this is the area that you'd usually check on an infant for CPR, the brachial artery. The femoral artery, which is inferior to the inguinal ligament. So it's usually right in the crease of where you would bend your thigh. The popliteal artery, which is posterior to the knee. And then the radial artery, which is the lateral aspect of the wrist. And this is going to be your most common pulse point, along with the dorsal artery of the foot, so the dorsalis pedis artery, superior to the instep of the foot. These are going to be your two biggest, the radial artery and the dorsal pedal. Okay? And then I would say followed by femoral artery and then carotid. Most of these you're going to have a difficult time actually feeling the pulse. I mean, try this yourself. Try feeling the superficial temporal artery or the facial artery. You might be able to feel your carotid artery, but I bet not too many of you feel the facial artery or the superficial temporal. Even the brachial artery, very difficult to find. The brachial artery is one artery that we used to draw arterial blood gases from. I could never draw them from the brachial artery because I could just never feel that brachial artery. I always drew them from the radial artery. Femoral artery, again, a difficult one to find. You really have to press kind of hard, and it's not very comfortable because you have a nerve right next to it. The popliteal artery, usually the patient is on their back. You have them bend their knee and then totally relax their knee, and you have to dig your fingers way up relatively deep into the back of their knee. Again, very uncomfortable. And chances of finding that pulse is kind of slim, or I should say at least difficult. But typically you will take a pulse at the radial artery, and if a patient is in the hospital, especially if the patient's a diabetic, then you'll check the dorsal pedal arteries on the top of the foot. And when you're checking someone's pulse, don't use your thumb. Your thumb has its own pulse. So you could be checking someone's pulse and thinking, hey, your pulse is as strong as mine. Okay, well, it is your pulse, So if you're checking your own pulse, it's okay to use your thumb. But if you're checking someone else's pulse, don't use your thumb. Use your first two fingers. Okay? And you can come back to me with that and say, wait a second. Last semester, you said your thumb is your first finger. Okay. Use your index finger and your middle finger to feel for the pulse. So, there you go. Okay, measurement of blood pressure. The top number again is going to be your systolic blood pressure. The bottom number is your diastolic blood pressure. What that means is the systolic blood pressure is the pressure within your blood vessel when your heart is contracting, when the ventricles are contracting. The diastolic blood pressure is the pressure within the vessels when the heart is relaxed. Okay? And when we're listening, first of all, we put a blood pressure cuff on. We pump that blood pressure cuff up, and it acts as a tourniquet, cutting off the blood flow. We put a stethoscope, usually over the brachial artery, at the antecubital fossa, in other words, the bend of your elbow. We start letting air out of the cuff until your blood is exerting enough pressure to push past that blood pressure cuff. Okay? So that first sound that we hear is going to be our systolic blood pressure. That's how much pressure it took to push past the blood pressure cuff. Okay? In this case, it looks like we're at about 120. Okay? And then we keep letting air out until we hear the very last sound. Okay, and that's at about 80. So this blood pressure is about 120 over 80, which used to be the normal. Now they're saying it should be below 120 over 80. So, but that last sound that you hear, that's going to be the diastolic pressure when the heart is relaxed. Now, shock is an inadequate cardiac output that results in failure of the cardiovascular system to meet the metabolic demands of the body cells. Cell membranes dysfunction, cell metabolism is abnormal, and cell death may occur. Some types of shock, we have hypovolemic shock, and that's where you're losing a lot of fluids or blood, so that would be hypovolemic. Cardiogenic shock, basically a heart attack, will put you in cardiogenic shock. Vascular shock, the blood vessels can all of a sudden dilate. That will drop your blood pressure, and you'll pass out, and you can go into shock that way. And then obstructive shock, that would be like from a massive embolus, like a pulmonary embolus. That can put you, or an air embolus, but that can put you in shock. Now, the homeostatic response to shock, we have activation of the renin-angiotensin-aldosterone system. Again, we'll go into more detail about this in the endocrine system, but basically, angiotensin is going to cause blood vessels to constrict. Aldosterone is going to hang on to fluid and keep you from peeing out fluid. All of that in an attempt to either raise or maintain blood pressure. The secretion of anti-diuretic hormone. If the doctor gives you a diuretic, what does that do? It makes you pee, right? So I call this the anti-pee hormone. Your pituitary gland secretes this, and basically, if you're dehydrated, then this is going to bind to your kidneys and have you retain and reabsorb a lot more fluid. So if you're peeing and your urine is dark, like a dark amber color, okay, as opposed to clear to light yellow, then you're secreting antidiuretic hormone, and you're trying to retain fluid. So drink more water. But that's going to happen during shock as well. Again, to maintain more fluid and to help maintain the blood pressure. And then activation of the sympathetic division of the autonomic nervous system. Okay, so the heart rate is going to increase, and you're going to have vasoconstriction in a lot of areas in order, again, to increase blood pressure. And then the release of local vasodilators, which you would think would drop blood pressure, but it depends on, again, where we're vasodilating. So usually we're going to have vasodilation of major organs in order to maintain those organs when the rest of the body's in shock. Signs and symptoms of shock: clammy, cool, pale skin. Tachycardia, in other words, a heart rate over 100. You're going to have a weak and what we call thready pulse. There's going to be sweating or diaphoresis. The patient's going to have hypotension, so the systolic blood pressure is going to be less than 90. There's going to be altered mental status, decreased urinary output, thirst, and typically the blood is very acidic, so we'll have acidosis.